this film reading session on the GI imaging, where this is the first case. Okay, and this is the contrast enhanced CT scan of the abdomen after oral and the intravenous contrast at the level of the liver, and there is a big lesion in the right lobe, and this lesion is heterogeneously enhanced. This is arterial phase. Then it is solid, and the diagnosis is yes, and this is the most common solid hepatic focal lesion, HCC, regardless the size and regardless the enhancement pattern. But you should consider the possibility, especially if the liver is cirrhotic. Then yes, polysplenia, and see this is an arterial phase of a contrast enhanced CT scan of the abdomen without oral administration of contrast media. Only you see here that the stomach is on the left side, that the liver is on the right side. There is no situs ambiguous, but the site of the spleen is occupied by multiple spleens. And whenever you are going to diagnose polysplenia, you should look for the IVC. This is very, very important. The liver may not be in the midline of the abdomen. In the stomach may be on the left side at its usual location, but you see multiple spleens, and you look to the IVC, and here the IVC is not present. Then what do you think? Yes, and this is hemiazygous continuation because the vessel is to the left side of the aorta. If it is to the right side, then you think of azygous continuation. Then whatever the site of the liver and also the site of the stomach, but in the presence of multiple spleens, you should diagnose this polysplenia syndrome, and after that you should look carefully for the continuation of the IVC. Okay. Okay, this is a contrast enhanced CT scan of the abdomen after intravenous contrast injection, no oral contrast media, showing a focal lesion in the right hepatic loop, segment number 7. Segment number 7. And this lesion looks cystic or solid? Solid. Then what do you think about these hypodensities? Fat. Okay, the solid lesion containing fat. Adenoma, hepatic adenoma, and the adenoma is a hypervascular lesion, and this was hydatid cyst. Okay, how can you predict this possibility? Actually, the main diagnostic criteria are lacking here: no calcium, no floating shadows, and no internal cysts. Then you have to decide first, is this lesion a cystic or solid lesion? But if you look carefully here and you see fluid density, if this is a solid lesion, it will show some enhancement, maybe. And the presence of fat is not one of the criteria of hydatid disease. And many times you can write in the report that this is, and I hate this word, this is a benign looking lesion in the liver, and it may require to have a biopsy to confirm the diagnosis. But This is, in my opinion, is not a solid lesion, and it is on the cystic aspect of the hepatic lesions. It is not a simple cyst, and is not an abscess, and is not a hemangioma. Then the remaining will be dehydrated, which is can be considered. Yes, air. No, if it is air, it will show air fluid level. No, no, it's not known in the hydrated cyst. Okay. طيب. By exclusion, otherwise you say that you are dealing with a benign looking lesion, and you recommend then further evaluation by ultrasound or by MRI to see the floating shadows, for example. Yes, and this is a CT scan of the abdomen at the level of the liver after intravenous contrast injection, no oral contrast injection. This patient had ovarian mucinous cyst adenocarcinoma, and yes, in the peritoneal cavity you see a lot of hypodense material, and this material characteristically indents the surface of the liver and the surface of the spleen. And this scalloping is very characteristic for pseudomyxoma peritoneal. Yes. And this is one like this one, but it is partial volume averaging. It is on the surface of the liver as well. Okay. And this is a selected section from a CT scan of the pelvis after oral, you see oral, and intravenous contrast material administration. Multiple intraperitoneal cystic lesions markedly distending the abdomen. Yes, echinococosis, peritoneal hydatid disease, disseminated peritoneal hydatid disease. Yes, and this is a CT scan of the abdomen with intravenous contrast injection, multiple linear hypodensities within the liver parenchyma of the right hepatic lobe, diagnostic of liver lacerations, and you should say that there is some collection or fluid in the peritoneal cavity, diagnostic of hemoperitoneum. This is, of course, the stomach. The spleen is not yet in the section. This is hepatic laceration with the hemoperitoneum. Okay. Calcular cholecystitis, abdominal ultrasound showing the gallbladder with multiple stones inside the gallbladder with characteristic posterior acoustic shadowing, the diagnostic of gallbladder stones. And do you think that this is polycystic disease or hydatid disease? Hydatid disease of okay. Then this CT scan is performed after oral only administration of contrast material, no intravenous contrast. You got multiple variable size cystic lesions in the liver and a huge one in the region of the spleen. The lesion in the spleen showed the characteristics of hydatid disease in the form of multiple mural cystic lesions representing the daughter cysts. Then if you see this lesion, which is characteristic for hydatid, and you see the lesions in the liver appearing like simple hepatic cysts, you should consider all as hydatid cysts. Okay. Yes, and this is CT scan of the abdomen after intravenous contrast injection showing multiple gallbladder stones containing air. And we have mentioned that gallbladder stones may contain air, and sometimes they contain fat whenever they are made of cholesterol, and the fat will appear more dark than the fluid in the gallbladder. And these are gallstones containing central gas, and the lesion in the kidney is a simple cyst and nothing else. This is a sclerotic lesion due to the degenerative diseases in the spine. Okay. Abscess where?
لا مش abscess ده blood في density multiple density.
Okay, some said that this is blood, others said that this is an abscess. And the contrast enhanced CT scan after oral and intravenous contrast injection showing. Number one, there is a big collection which is posterior to the kidney, and the kidney is healthy. The kidney is not injured. And this collection showed the marginal enhancement. Then, if you look in the peritoneum and you see other collections within the peritoneal cavity with marginal enhancement of the peritoneum and multiple air fluid levels in the intestine. And this is due to ileus. If there is an infection in the peritoneal cavity, it will lead to ileus of the intestine. And this is peritonitis with intraperitoneal and retroperitoneal abscesses, as well as ileus of the small bowel. And before predicting that this is a perinephric hematoma, then you should look at the kidney. The hematoma in the kidney or around the kidney will be associated with some injury of the renal parenchyma and a good history of trauma, as we have mentioned before. And this is the CT scan without intravenous, or let us say with intravenous and oral contrast, and this is the follow-up of this case after surgery. What do you think? Hydatid. Yes. And you see a cystic lesion with multiple mural cysts and a faint rim of marginal calcification. And I said that the treatment of hydatid cyst in the liver is surgery, not aspiration, surgery, because of the fear of that this cyst may rupture and produce many peritoneal disease. Then after removing this hydatid, then you should fill the operative bed with something, and this something usually is part of the omental fat, because if you left this as a dead space, it will collect fluid and will be secondary infected after this. And this is fat from the omentum. After you remove the hydatid, and you fill the space by omental fat. Okay. And he said there are two main possibilities. Either this is bizarre or this is a missed operative gauze. Then the missed, yes. And this is a missed surgical towel or surgical gauze. It has a very characteristic appearance of a mass with internal trapped air loculi. Of course, there should be a positive history of surgery. Then if you look carefully here and you see some dilated bowel loops with air fluid levels, meaning that this is a mechanical obstruction, that the lesion is obstructing the bowel leading to intestinal obstruction. And this is common because this bowel will initiate an inflammatory reaction in the peritoneum, and it may lead to adhesions, and adhesions will lead to intestinal obstruction. Many times, and you can see some radio-opaque strands within this towel, and these are the markers. Because in many operative rooms, they use the C-arm to look for any missed towels, and the only indicator is the presence of linear hyperdensities representing the marker on the towel itself. Okay. Pancreas malu. Okay, and there is this is the CT scan of the abdomen after intravenous contrast, and you see that there is some enlargement of the pancreatic head, and this is the common bile duct stent. If you no, this is not a stone, this is the stent, and they see interrupted dilatation of the of the main pancreatic duct. Interruption is very important because if this is the pancreatic head carcinoma, then it will lead to diffuse uniform dilatation of the hepatic duct. Then what do you think of this tumor, of this lesion? IBMN. Yes. Then you remember this IBMN is an intraductal mucin producing neoplasm. And we have said that there are two types: the type which affects the main duct, and the type which affects the branches, and the type which affects both. This tumor, according to the literature, is very, very frequently diagnosed nowadays. Very frequent, and you have many cases in the archive of this tumor. Now, then, what is the reason of being diagnosed is the high resolution imaging. It was not known before that, but this is one of the tumors that is well known nowadays. IBMN. There are two types, benign one and the malignant one. Then how can you predict the malignancy of the tumor? By the presence of signs of malignancy, lymph nodes, hepatic deposits, peritoneal involvement. But if you do not see any sign of malignancy, and this IBMN may be a benign lesion. And there is a good association between this IBMN and pancreatic cancer. Both can exist in the same patient. You predict the diagnosis by focal dilatation of the pancreatic duct, focal dilatation, or interrupted dilatation of the pancreatic duct. Then you know that you are dealing with this particular tumor. And what about the liver?
Liver في multiple focal cystic lesion.
Okay.
في cyst كبيرة كده في الtail of IBM.
Okay. And the diagnosis is for polycystic disease. No, this is not polycystic disease, of course. Okay, this is post-contrast CT scan of the abdomen after oral and intravenous contrast material. You see a cystic lesion in the tail of the pancreas, and you see multiple focal hepatic lesions. Then if the tumor is cystic, then you expect that the metastases are cystic, and this is common in the ovary and in the pancreas. And you can see cystic neoplasm carcinoma, of course, in the tail of the pancreas with multiple cystic, hepatic, metastatic deposits. And this is not polycystic disease. Polycystic disease primarily affects the liver, the kidneys, to a lesser extent the spleen, and to a much lesser extent to the pancreas. Okay. Yes, and this is ultrasound of the gallbladder, which is distended, containing two masses inside the gallbladder in a patient known to have malignant melanoma, diagnostic of metastatic deposits in the gallbladder. We know that metastases can affect any part of the body, especially the melanoma, of course. Okay. Who said emphysematous? Emphysematous of? Emphysematous gastritis. And you see air in the wall of the stomach? No. Okay. What is the type of this examination? Is barium mean. And this is, of course, the stomach. Unique. Unique? Okay, where is the disease? In the proximal part of the stomach or in the distal part of the stomach or the whole stomach? Yes, they see that the distal part of the stomach is regularly distensible and the mucosal pattern is good, but the region of the fundus and the proximal part of the body are markedly reduced in caliber and in the lumen with irregularity of the wall. Then you consider malignancy. And what is the suspected type of malignancy? Here is carcinoma of the stomach. The carcinoma is more distal than lymphoma, but a carcinoma can occur proximally also in the stomach. And both lymphoma and carcinoma can reduce the gastric lumen, either focal or diffuse. One. Spleniole. And fatty liver. Yes. This is post-contrast CT scan of the abdomen, oral and intravenous. The liver is fatty because it looks hypodense compared to the splenic parenchyma, and there is a spleniole. The spleniole is the son of the spleen. Let us say that, and it should look exactly similar to the splenic parenchyma in all imaging modalities, in ultrasound, in CT, and in MRI. Okay, and then this is barium swallow showing a filling defect in the esophagus, and this filling defect is intramural filling defect, and it may have a smooth surface, and I said before that such lesion is usually suggestive of an esophageal leiomyoma, but consider that this is one of the appearances of carcinoma, because carcinoma of the esophagus is commonly of the stricture type and less commonly of the bulboid type. Then if you see a lesion like this, and also you can see this fleck of barium which represents an ulcer on the surface of the tumor, and you should know that leiomyoma almost never ulcerate. Leiomyoma, according to the literature, almost never ulcerate. Which tumor can ulcerate in the esophagus? The carcinoma, of course, and the GEST tumor, stromal cell stromal tumor, and it is also a known lesion in the esophagus. But according to the literature, 100 cases of leiomyoma against a single case of GEST in the esophagus. Leiomyoma is by far very common in the esophagus, and whenever compared to the GEST tumor. Then if you compare leiomyoma in the stomach by GEST tumor, GEST is by far the most common site of GEST in the GI is the stomach.
مش leiomyoma اصلا تحت الجست؟
يعني ايه تحتيه؟
يعني
قصد لازم القرية
هي leiomyoma sarcoma الجست.
Yes, and then these leiomyoma and leiomyosarcoma have these terms have been replaced by the GEST tumor in the stomach. But in the esophagus, leiomyoma is still existing, and GEST tumor is also seen because of the difference of the layer of origin of the tumor itself. Then if you see a lesion like this, and you may say safely that this is leiomyoma. But if you look carefully and you see some irregularity and an ulcer on the surface of the tumor, you may think that this is a carcinoma. What is the diagnosis? Okay, and this is CT scan of the abdomen after oral and intravenous contrast, and you see many focal lesions in the liver. The liver is not cirrhotic, and in there are many differential diagnoses for this, because hepatocellular carcinoma can be multiple, lymphoma can be multiple, metastasis can be multiple. And if the liver is cirrhotic, they think more in hepatocellular carcinoma. If you see focal lesion in the spleen, then you think of lymphoma. If you have a known primary malignancy, then you think of metastasis. If not, look to the surface of the liver. If the liver is not cirrhotic, you can exclude the possibility of HCC multifocal. Then you think of metastasis and the lymphoma. Both can have the same appearances. Okay. The head of the pancreas, what? Okay, and this is a CT scan of the abdomen after intravenous contrast injection. This is the head of the pancreas, and this is part of the duodenal loop containing fluid like this loop. And what's wrong here is this vessel. Right? Yes, and this is devoid of enhancement, meaning that it is thrombosed. And also the relation between the superior mesenteric artery and vein is reversed. This should be the site of the artery, and this should be the site of the vein. But here you see the vein is occluded and the artery is patent compared to the aorta. And you may see some fluid levels within the intestine. You got, if the superior mesenteric vein is thrombosed, it will lead to ischemia, and ischemia will lead to ileus, and ileus will show multiple fluid levels. And also the rotation in itself, it can cause some obstructive symptoms. This is the head of the pancreas, and this is the duodenal loop, this area. Okay. Yes, and this is the cystic lesion in the pancreatic body and tail. This is the body and tail of the pancreas, and you got a cyst. And this cyst is posterior to the stomach, which is compressed and displaced anteriorly. What is the possibility? Yes, pseudopancreatic cyst. cystic lesion unilocular in the pancreas should be considered as pseudopancreatic cyst. If the cyst contains air, then you think of pancreatic abscess. But in absence of air, you cannot differentiate between the pseudocyst and pancreatic abscess. Okay, and this is an arterial phase, contrast enhanced CT scan of the abdomen showing multiple strongly enhancing pancreatic lesions, and these are hypervascular metastases from renal cell carcinoma. Multifocal ممكن, and this may be multifocal insulinoma if you don't know the history, but consider the multiplicity in favor of metastasis. And if you don't know the history and you see multiple lesions in the pancreas, and consider metastasis first. Okay, this is pancreatic deposits from renal cell carcinoma. Yes, and this is mesenteric panniculitis, CT scan of the abdomen after intravenous and the oral contrast median. You see this haziness in the peritoneal in the mesentery, and if you look carefully around the vessels, you can see the classic fat halo sign around the vessels, which is diagnostic of mesenteric panniculitis. And this is a non-inflammatory condition, usually asymptomatic. Splenic focal lesion. Splenic focal lesion. Okay. This is the after oral and the intravenous contrast, and you see a lesion in the spleen, and the lesion is solid, and the most common solid lesion in the spleen is due to lymphoma. And this is the body of the pancreas, the splenic vein, and there is some partial volume averaging here. The neck of the pancreas is not appearing in this section, and this is the IVC, or this is the portal vein or the IVC. This is the IVC, I think, and this is the splenic vein, and this is the portal vein. Okay. This case is a case of a blunt abdominal trauma, and is performed after intravenous contrast injection. Okay, and this is of course the pancreas, and they don't see the spleen. Maybe this is the very small part of the spleen, and the pancreas, the body is shattered, and they say that this is a fracture of the pancreas with a pancreatic hematoma at the site of laceration, and this is an infrequent case in the clinical practice. May be seen in the children, also in adults, and the frequent. Yes, this patient is known to have a bronchogenic carcinoma and is imaged for the possibility of adrenal deposit. There is an adrenal mass in the pre-contrast scan. It shows -19 Hounsfield unit, After injection of contrast, it showed significant enhancement. Then, what do you think? And we don't have the wash out. And this is regular adenoma because of the density in the pre-contrast. كلام مقدس يعني عارف مش قرآن كريم. Okay. Yes, if you see the reading is by minus, then you don't see gross fat by the naked eye, because gross fat meaning that this is a malar album, but you don't see gross fat like this fat, for example, in the retroperitoneum, and the reading is by minus, and you know that this is a rich lesion with fat, and you consider, and this is one of the exceptions in the adrenal gland, that the patient may have a primary malignancy and you say no, this is not metastatic deposit because of the classic appearance of the regular adenoma. Colodocal cyst, and this is MRCP showing fusiform dilatation of most of the common bile duct with normal intrahepatic biliary radicals, and this is type 1 colodococyl or colodocal cyst, which involves the whole or almost the whole length of the common bile duct. Okay, and this is a barium male showing a big filling defect in the gastric fundus with thickened mucosal folds. And you remember that I have said that the bezoar should contain air loculi within its merenchyma. And this is a big mass in the fundus of the stomach with prominent mucosal folds, and this is lymphoma of the stomach. These are the different appearances of lymphoma of the stomach. The stomach may be involved by lymphoma and it looks normal in the barium study. Filling defects, thickened gastric mucosal folds, rhinitis plastica, and ulcerative lesions are the manifestations of lymphoma in the stomach. Yes, and this patient with sickle cell anemia, CT scan of the abdomen without contrast, they see marked, very dense calcification of a small spleen, diagnostic of autosplenectomy, which is a known condition in sickle cell anemia patients. Pneumoperitoneum, regular sign, and you see this air is outside the lumen of the bowel. Look carefully here. This air do not confirm with any of the bowel, and it is usually located at the falciform ligament. And here you can see the wall of the stomach, and you see the wall of the colon, and this is diagnostic of the pneumoperitoneum on a regular sign. Biliary cystadenoma. This is a contrast enhanced CT showing a big cystic lesion in the liver with internal septations suggestive of biliary cystadenoma. Yes, this is the CT scan after intravenous and oral contrast material of the abdomen showing marked thickening of the small bowel loops, encroaching significantly on the lumen, and this is diagnostic of lymphoma of the small bowel. This is an HIV positive man with contrast enhanced CT scan of the abdomen showing many focal lesions in the spleen and many other focal lesions in the liver. And this is known as a spotted spleen, which is for a list of differential diagnoses, including inflammatory and neoplastic. And I have mentioned that whenever you are confronted by a patient with immune suppression, then you think of fungus, and you think of fungus, and yes, and the liver is not immune from fungal infection. In patients who are immune suppressed, either due to HIV or due to cancer and chemotherapy, and you got many focal lesions in the spleen, one of the best diagnoses is fungal abscesses in the liver and in the spleen. But yes, of course, I know this, and this may represent lymphoma. If you are sure that these lesions are solid. But many times we use ultrasound and the MRI to be sure that these lesions are not solid but cystic. Then whenever if you say that I would suggest the possibility of fungus and the possibility of lymphoma, then you are right, no problem for this, but you should include fungus in the differential diagnosis. And this is MRI of the abdomen, T1 and T2 weighted images with fat suppression, and you see multiple cystic lesions in the right hepatic lobe together with dilated intrahepatic biliary radicals. This is cystic lesion, and it is not solid to suspect a cholangiocarcinoma. But in the presence of dilated bile ducts, tubular and cystic, and the possibility of Crowley disease. The dot sign is not present here. Okay. Multiple. Then contrast enhanced CT scan of the abdomen, and you see multiple subcapsular and another lesion showing marginal enhancement, diagnostic of abscesses. And then do you see the gallbladder cholesterol polyps? These are the abscesses, and this is the gallbladder with a thickened wall, and maybe these are the cholesterol polyps. Yes, avulsion of the renal vascular pedicle, the CT scan with contrast intravenous. You see an enhancing right kidney and a non-enhancing left kidney, denoting the avulsion of the renal vascular pedicle, considering the history of trauma. Yes. And this is a barium study for the gastroesophageal junction, showing multiple filling defects in the mucosal prominence in the gastric fundus, and the varices are usually of a smaller caliber compared to these very big filling defects. Then you consider this as lymphoma affecting the lower esophagus and the gastric fundus, or carcinoma affecting one of both anatomic regions and extending to the other part, and this was gastroesophageal lymphoma, based on the prominence of the mucosal folds and the long segment of involvement. Yes, acute pyelonephritis with swollen right kidney, striated nephrogram, poor renal function, and stranding of the perinephric fat. These are the criteria of acute pyelonephritis. Crohn's disease حد قال كورونا. Okay, the lesion is here. No, the appendix cannot be 3 meters long. Yes, this should not. This is a very, very, very long structure to be the appendix. This should be an ileal loop, and the ileal loop is thickened. The wall is thick and enhancing with reduced caliber, and the only lesion that can do this is the Crohn's disease. Okay. Yes, contrast enhanced CT of the abdomen, and they usually term this as hydro CT. Hydro meaning that you let the patient to drink water instead of contrast material, because it can induce better differentiation of the tumor against the water. Then a mass in the stomach may have some possibilities like gastric cancer and lymphoma and gastric tumor and metastasis as well. Also, you can see lymph node here, and lymphadenopathy is not a feature of gastric tumor, but it is a feature of lymphoma and carcinoma. And if you see that the lesion is focal and you are towards the side of carcinoma more than lymphoma, and this is gastric cancer with lymphadenopathy. Yes, there is blunt abdominal trauma with significant laceration of the lower ball of the left kidney and the fluid in the peritoneal cavity, diagnostic of hemoperitoneum. And if this is the spleen, it will be also affected, and I am not sure about this. But this is renal and splenic lacerations with hemoperitoneum. We are not sure about this section, but this is a contrast enhanced CT scan of the abdomen, and this is of course the aorta. And the aorta is composed of two main parts, an enhancing part which is the patent lumen, and this very big non-enhancing part together with some fluid in the peritoneal cavity, meaning that this is an aortic aneurysm which has been ruptured or leaking aortic aneurysm. And this is barium meal, double contrast barium meal, and showing polyps in the stomach. The polyps in the stomach have a long list of differential diagnoses. The most common is hyperplastic polyps. Then you got adenomatous polyps, which is precancerous, and hamartomatous polyps, like those with Budd-Sugar syndrome and others. And also you consider that carcinoma may present as a polypoid filling defect. Also the gastric tumor can present like this. The differential diagnosis of gastric polyps include hyperplastic is the most common, then post-inflammatory and adenomatous polyp, which is a precancerous, hamartomatous polyps, and eosinophilic granuloma. Yes, and they see that this CT scan of the pelvis, and they see there is a lesion here in the, possibly in the sigmoid colon, with significant mural thickening and encroachment, marked encroachment on the lumen And you may see some stranding of the fat around the colon. This is not an issue. And the diagnosis is carcinoma of the sigmoid colon. Yes, here. No, divertically you should see a significant number in order to say that this is a diverticulitis. Then yes, this is volvulus of the mesentery of the small bowel. You can see the area of the region of the splenic of the superior mesenteric artery and the vein is replaced by whorly appearance and disturbance of the vascular anatomy associated with intestinal obstruction and dilated loops with multiple air fluid levels, and this is volvulus of the mesentery or mesenteric volvulus. This is a gunshot injury of the abdomen after contrast injection, and you see lacerations of the liver and lacerations of the, you think that this is laceration or enhancement in the arterial phase. This may be due to enhancement in the arterial phase, not homogeneous. But if this is the track of the gunshot, possibly, and it will affect the liver only, and you got horseshoe kidney, an incidental finding. Yes, and you should locate the anatomy of the lesion, and we have a very big cystic lesion in the peritoneum with internal septations. Diagnostic of the most common lesion in the peritoneum containing internal septations is lymphangioma of the mesentery. Yes, mesenteric lymphangioma is a big lesion in the peritoneal cavity, cystic, containing multiple internal septations, usually seen in the pediatric age group. Okay, and this is hydatid cyst showing classic appearance in the spleen. Cystic lesion with multiple internal floating shadows. Diagnostic of hydatid cyst. This is one of the typical and the classic appearances of the hydatid anywhere in the body. Yes, you see that there is significant restriction. This is barium meal with significant restriction of the distension of the distal part of the gastric body, as well as the pyloric canal, with marked irregularity of the wall and the proximal retention of gastric residue and food particles. Diagnostic of gastric carcinoma. Yes, the gallbladder wall is thick and there is a shadow here, and this may be, is it associated with acoustic shadowing? Okay. Then what do you think about the ecogenicity of the gallbladder content? Is due to mud. Porcelain gallbladder. This is not the gallbladder actually, and this is gallstone ileus. This is the gallstone which is impacted in one of the intestinal loops, and you got intestinal obstructive changes with dilated loops and multiple air fluid levels. Diagnostic of gallstone ileus with a small bowel obstruction. Yes, and this is This is arterial phase and this is portal phase of the abdomen, showing a lesion or a mass or a polyp or in the gastric pylorus. Then what do you think? Carcinoma, lymphoma, metastasis, GIST. Yes, and this is GIST. GIST is a good possibility for masses inside the stomach, especially if there is ulceration. And you know that GIST will ulcerate whenever it is large. But the small types of GIST are usually towards the benign aspect and they do not show ulceration. Yes, and the most contrast is CT scan of the abdomen after oral and intravenous contrast media administration showing splenic laceration with perisplenic hematoma and hemoperitoneum. تمام. Okay, there is the CT scan of the abdomen, axial and coronal reconstruction showing big mass near the anatomic location of the cecum. And the mass contains a gastrographene inside as well as fluid and air, meaning that it is of bowel origin. Then do you think that this is small or large bowel? Okay. Yes, and this is the cecum. Then which is more common in the large bowel, lymphoma or carcinoma? Yes, and you should, if it is a small bowel, you prefer the diagnosis of lymphoma. If it is a large bowel, and the carcinoma may show this, but also one of the criteria of lymphoma is this marked mural thickening and trapped gastrographene within the lesion. Mass in the gallbladder by ultrasound, diagnostic of gallbladder carcinoma if the lesion is more than 1 centimeter. If it is less, then you consider differential diagnosis like cholesterol polyp, adenomatous polyp, metastasis, gastric carcinoma, and so on. Gallbladder carcinoma. Yes, and this is the plain X-ray of the abdomen showing the classic appearance of a sigmoid volvulus with coffee bean appearance. There is a huge dilatation and bending of the sigmoid colon, diagnostic of sigmoid volvulus. Crohn's disease and spot film on the terminal ileum from a barium meal follow-through study showing the irregular luminal narrowing of the terminal ileum with areas of stricture, diagnostic of Crohn's disease of the small bowel. هذا وبالله التوفيق.